Um, Same day start, I talked about, and I should mention actually that we do have some criteria by which we screen folks that we think would be eligible for same day start, even if they don't necessarily feel an urgency to same day start. And those criteria are listed there. And then when we do same day start somebody, we actually capitalize on the intermittent prep data, the IPRGA data, pharmacokinetic data, and essentially double dose start people. So normally you would take one pill per day. But we know from the intermittent prep data that essentially if I was going to have sex, let's say on Friday, I would take 2 doses of Truvada to start, and then 1 dose 24 hours later, and 1 dose another 24 hours after that. So 4 doses over 3 days. And the idea being that in general, we know it takes at least 7 daily doses of Truvada to be protective against HIV if your potential exposure is in the rectal compartment. We think it's 21 days if your exposure is vaginally or potentially penile insertive as an exposure. But so instead of saying, we have 7 days to get you to where you're protected, the IPRGA study showed that if you double dose start somebody, then you can sort of overcome that pharmacokinetic time to therapeutic preventive effect. And so we take, even though this is a little bit of a different flavor, we essentially double dose start because, again, what's the downside? And if you can sort of boost their levels earlier on, then probably you have that same pharmacokinetic effect. Another thing that we're really proud to be able to do is to offer PrEP to minors, so under 18, without parental consent. So a lot of what we do with youth in the HIV world and in the family planning world, essentially says that youth should get the prevention and the services treatment that they deserve, that they need for HIV treatment, for pregnancy, prevention or termination, even if there isn't a parent who can consent to that care for the safety and the well-being of that youth. And so we feel very strongly about that same carve out for minors who are seeking HIV prevention. And so we attempt at every junction to get parental consent or guardian consent or somebody's consent who sort of has who cares for that child, for that youth. But in the setting where getting parental consent or guardian consent is impossible, i.e. there's no guardian involved, or dangerous to that youth. So if that person talks to their mother about accessing PrEP and their mother doesn't necessarily know they're gay, and that leads to potential poor outcomes in terms of physical or sort of verbal, emotional abuse, then we don't want those things to have to happen, those life events to have to be incurred because somebody wants to start on PrEP. So we have codified policy to that end, and because we're a community-based organization and not a large academic center, we have a little bit of a leg up. We don't have a whole huge legal team that has to review that. So if anybody is interested in seeing that and wants to develop similar policies for their practice, we're happy to share those materials. And they essentially basically use a lot of the same language that we use for all of the other carve-outs that we would give to minors. And then I think second to lastly, but I think one of the biggest things that I want to focus on today is the importance of monitoring adherence. So we've heard that and we know that everything about HIV prevention is adherence. So in the different studies that led to the approval of PrEP and all of the different data in all the populations that we've studied in the big sort of multi-site international trials, we know that efficacy in terms of HIV prevention is directly dependent on adherence. So overall in the IPREX trial, that was 2499 MSM and transgender women, overall efficacy was 44% in all comers. But when you looked at those who took PrEP consistently, meaning they had some detectable level in their blood, it was 92%. And in those who took PrEP daily, it was 99%. So this is, again, 99% is better than any other preventive modality we have, better than the flu shot we all get every year, better than the pneumonia vaccine we advise all of our vulnerable patients to get, better than malaria prophylaxis. It's better than anything that we've ever been able to offer in the infectious disease world for prevention. But the trick is you have to adhere to it. And when you're talking about vulnerable populations, and particularly youth, who, for anyone who's served youth and young adults, the transience, that's just a part of their life, makes adherence really a struggle, more so even than it would be for us, and it's often a struggle for us as well. And so we've really structured our entire program around really supporting adherence. So youth in particular, this is a study from, this is a chart from Sybil Hosek's data, Project Prepare in Chicago, where she looked at the same age group. And you can see that self-reported adherence to PrEP over a 24-week period was excellent. So started around 70 and actually ended up higher at 80% of youth saying that they were adherent over a 6-month period. But when they actually looked at plasma levels, adherence truly started just above 60 and ended up at about 20% at 24 weeks. And I didn't include it in this talk, but I think really the most concerning graph that really spoke to us was that if you break this down by race ethnicity, if you look at the youth of color, not 1 minute during that entire 24-week period were any of them protected against HIV. So their adherence was the worst amongst this cohort. And so that told us, we are not doing the right things to be able to support our youth in taking medication. So we know that youth can take medication, and we've seen that firsthand in our practice, and I'll show you our data. But it's not can they take medicine, it's how can we help them take medication. And if what we're doing isn't working, then we have to think of new ways to do that, because this is the highest risk group. So again, if adherence is everything, how are we prescribing PrEP without being able to follow in any objective way, their adherence? When we take care of people living with HIV, what would we do without viral loads? How many times has someone said, "How are you doing? Are you taking all of your meds?" "Yes, I am." And then we send labs, and a week later their viral load's 20,000. And despite the fact that you thought you had a good rapport with that person, for whatever reason, they didn't want, they felt bad, they forgot, they didn't want to tell you that they hadn't been taking meds consistently, and you call them on the phone and say, "Hey, you got a viral load of 20,000. What's really going on?" "Okay," and then you have a real conversation with that person about, this is what's going on. How can I help you through that? Because this is important. This is your life. And so we don't have that with PrEP. And that is a very big problem, because right now, the number of Truvada prescriptions in this country for PrEP is 34% greater than the number of Truvada prescriptions in this country for HIV treatment. So PrEP is taking off, and it's not really taking off so much in these sort of most high-risk populations as much as older people in their 30s, who are like really aware. Every year when I make this talk, I feel a little bit older. But it's not really taking off in these groups, but PrEP is taking off, and yet it's all about adherence, and there is no way to objectively monitor adherence here and now in your practice setting. So this is an issue that we really sought to address. And again, because it allows you to, again, CDC has all these recommendations in the packet about individualized adherence planning, which is wonderful, except that it's really hard to then have that person, if you don't have that conversation with somebody, if you don't really have a way of knowing if they're fully adherent. And if anybody has a teenager in the room, folks, I think I took something. I feel like I took one yesterday. I mean, it's really difficult to have those kinds of conversations, even with the most well-meaning adolescent who's really trying to do right and doesn't have a crazy lifestyle where they're living on the street or on someone's couch. Adolescents and youth are they got other things going on. And so this is critical for this population. So we developed a urine test that monitors the level of tenofovir in the blood. As you know, tenofovir is one of the two components of Truvada, tenofovir emtricitabine. Essentially what happens in our site is that our patients give us a urine sample. Usually this is in conjunction with urine samples they're giving us for gonorrhea, chlamydia screening, trichomonas, et cetera. So typically it's not even an extra test, although sometimes we do run it specifically for adherence monitoring. And we send that over to CHOP, Children's Hospital of Philadelphia, with which we collaborated to do this. And we get a result back that essentially tells us the level of tenofovir in the urine. And I'll show you sort of how we use that. And that allows us to have that real conversation with our patients about adherence support. So the urine test is uses mass spec, liquid chromatography, tandem mass spectrometry. It's very highly sensitive and specific for tenofovir, and essentially has 100% concordance with the plasma levels that are used in all of the IPREX trial, the VOICE trial, the FemPrep trial, TDF trial. Tenofovir is detected for about 7 to 10 days actually in the urine after you take a single dose. So essentially what the urine test tells you is it gives you information about really only that last week to 10 days. But again, with our youth, knowing what's going on right now as opposed to 2 or 3 weeks ago or 2 or 3 months ago is really critical. And so this is how we interpret it. So basically there are these 3 sort of cutoffs. Greater than 1,000 means that they've taken, this is nanograms per mil, greater than 1,000 basically means that they've taken their Truvada in the last day or 2. And so that tells us that as of that moment when we're checking them, they are protected against HIV. If you look at the bottom, anything that's essentially 0, less than 10, tells us they haven't taken medication in the last 7 to 10 days. So they are certainly not protected against HIV, and this is a great group to be able to target your adherence support interventions to. They are not taking it. And then you have that middle group that's somewhere between 0 and 1,000 nanograms per mil, and that is also a really important group. And this tells you a lot about adherence patterns, because that's a group that's taking a little bit of PrEP, but they're not taking it enough. They haven't taken it in the last couple of days, but they have taken some in the last week. And so this is a group where you can really say, okay, you're not only not protected against HIV, but if you were to acquire HIV, you then are the person that may be at risk for developing resistant virus in this sort of setting. And so those bottom 2 groups are groups that we really target our adherence support interventions to. That top group, that I've taken it in the last day or 2 group, doesn't mean they've taken it perfectly for the last 3 months since you've last seen them. So that's the caveat there. And when we talk to people about those results, we don't say, hey, great job, do exactly what you're doing. You know, we specifically counsel them, but this allows us to say, at least for those bottom 2 groups, we know that you guys are struggling with adherence. Let's talk about it. And for that top group, we remain cautiously optimistic as we see and follow people over time. So I want to share with you some results that we presented at IAPAC in Florida last week, basically to show whether or not this test can be used in an ongoing basis in a clinic setting over a 1-year period. And so essentially we wanted to assess what was our adherence over that time period, and then of course what was our retention and care over a year-long period. And retention we defined, everybody has, I think, defining retention in care in the HIV land is sort of well established. Defining retention and care in PrEP land is a little bit harder, because your goal is not necessarily to have every single person you start on PrEP be on PrEP a year later or 2 years later or 5 years later. Your goal is to educate people about how to stop and start it in conjunction with a healthcare provider in a way that safely and meets their needs, and to match their level of risk awareness with our perception of risk awareness, while having sort of an ongoing conversation, which is really hard to sort of then say, well, what's the success of your program and how many people are retained and how many people fell out of care because they fell out of care and you need to go sort of bring them back, or how many people fell out of care because they actually made a really well-informed decision to stop PrEP based on the termination of a risk factor that had been in their life. We also looked at changes of STI rates in this young high-risk population, and then assessed attitudes overall towards PrEP. All of our subjects were recruited from our IM Men's Health program. And again, we administered PrEP weekly, every other week, or monthly. We included up to age 30 in this cohort, 18 to 30, and we assessed risk behaviors through our risk assessment battery.